Before we get started, I have a quick favor. I've been self-funding the Finding Genius podcast for 5 years now. I've done over 3,000 episodes. And as you can see on YouTube, we're up over 1 million views on the channel, which is fantastic. The next thing I really want to push on is to get up to 10,000 subscribers. Because once we do, we'll be able to put a donate button and we'll be able to solicit donations to help keep the podcast running and to also get the Finding Genius Foundation moving along. We have a big project studying anxiety, depression, and PTSD and working on a product to help people overcome these problems because I've seen them explode recently after the last 2 years of the whole virus situation. So if you would, please subscribe to the podcast. That would help us tremendously. Give us a thumbs up and check in the description for Buy Me a Coffee. It's about $5. If you could buy me a coffee, I'd really appreciate it. It would help keep the channel going, and I love coffee. Thank you.
Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. My guest today is Dr. Julie Siemers. She's an author. The book's called Surviving Your Hospital Stay: A Nurse Educator's Guide to Staying Safe and Living the Telepath. So we're going to talk about hospitals, and they may not be the best places for people to experience good health. And some people never leave the hospital, which will be, crazy to hear, but it's the truth. So welcome, Dr. Julie. Thanks for coming.
Thank you for having me.
Yeah, if you would, tell me a bit about your background and how you got onto this topic.
Yeah, so I've been a nurse since right out of high school. It was a suggestion my mother made. Hey, Julie, why don't you be a nurse? And I thought, yeah, that sounds like a pretty good idea. So I spent a lot of time in the hospitals working in the ICUs, worked in the trauma center for a while, and then spent 10 years as a flight nurse on the trauma helicopter. That was amazing. And then in 2009, I entered nursing education, which started me on the path to my master's degree. And, this time I'd been teaching, finding out that discussing case studies with students that harm was happening to patients. So that's why I decided to do my master's thesis on failure to rescue, which is failing to recognize signs of deterioration. So for 15 years, I've been continuing that journey in exploring why patients still suffer preventable harm in the hospital. I finished my master's thesis on that, and then I did my doctoral project. So kind of brings us here to today.
So what have you discovered? What are the main causes of harm to people in the hospital?
Oh, goodness. There's a myriad of them. As you know, I read a little bit about your background too, that hospital systems and healthcare is a very complex system, right? But what I found was over 250,000 patients die from preventable harm each year, and many, many more are harmed in the healthcare system. In fact, the Department of Health and Human Services put out a study a couple of years ago, so it's really pretty recent, that 1 in 4 patients experience some kind of a harmful event in the hospital. It's crazy, isn't it?
Well, what is a harmful event? What does that mean?
So it can be healthcare-acquired infections that can cause harm or death. It can be a misdiagnosis. In my book, I wrote stories about these different aspects of how patients are harmed in the hospital, but I wrote it for hope for patients and their families to try and understand the healthcare system a little bit better and become informed. When you're informed, then you're prepared. So diagnostic errors, one of the stories was a young father of a couple of children who had a headache, went to the doctors, had a brain tumor. They said during surgery it didn't look like cancer, so not to worry about it. Well, the pathology report came back that it was cancer, but that report was misfiled somewhere. The doctor didn't report it to the husband, the patient, and his wife. And 6 months later, when his headaches returned, he went back to the hospital, and this time the tumor was the size of the surgeon's fist. And it was malignant, and unfortunately, he didn't survive the treatment that they implemented at that time. Had they implemented it the first, 6 months earlier, he may be still alive. So diagnostic errors are another really important part of harm that happens to patients. They estimate that about a third of all patients that go to the hospital into the ER have a misdiagnosis, either a late diagnosis or wrong diagnosis. So that's a couple of the ways. Another big one is nurses failing to recognize the patient that is deteriorating. So, for example, one of the complications that can happen postoperatively is pneumonia. And a precursor to that is the patient not taking deep enough breaths after surgery to fully expand the lungs after, laying there for a little while and getting pneumonia. But the implications of pneumonia are always seen before the actual deterioration event into cardiac arrest. So, for example, the patient's respiratory rate will increase, the heart rate will increase. And those signs, the literature and the research says happen 6 to 24 hours prior to a cardiac arrest. So that's another big area of opportunity, is not missing those signs of deterioration in a patient.
Well, I mean, nurses do rounds. The doctors barely come, but the nurses, I mean, how often are they looking at patients, or are they just looking for acute problems like the person's coding or something, or,
Yeah, there's, short staffing that is around the country, and that's part of the problem. The nurses don't have as much time to assess the patient, but again, there should be watching for those critical signs of changes in neurological status. That's probably number two. Number one is respiratory rate. There's many studies that validate nurses don't actually count the respiratory rate. They just kind of make up a number between 14 and 16, which is the normal range we learn, in school, but they weren't taught the actual physiology behind early deterioration of, the physiological condition, and therefore would understand respiratory rate is a key indicator. It's the most sensitive and earliest indicator of patient deterioration.
Okay. Root causes, what is it? Is it just the nurses are coming and not really looking at the patient? They're just, how are you today, running off a script and then leaving? Like, is there anyone that's supposed to come and actually just beyond a few vitals to actually assess what's going on with the patient? I mean, I've been asked, how are you feeling? What's your level of pain? They do your blood work, they do the vitals, all this other stuff. Like, why would things be missed so often?
Well, because nurses are taking shortcuts. When I was at my last university, I left in April. I was there with 2,700 students on a campus in Los Angeles. And I would ask the students, and they say that nurses aren't doing assessments of their patients, i.e. listening to breath sounds, checking for edema or swelling, or checking circulation with pulses in the extremities, those kinds of things. The nursing students are taught this in nursing school, but they say they don't have time. So they miss the head-to-toe assessment. That's one of the reasons.
How do they not have time? That's their job.
Well, it is their job. You're right. What I find is they're hurry up to get the medications out. If they have 6 or 8 patients, medications, and then get patients down to diagnostic procedures, or now they have a new admission from the ER. Yeah, I remember those days. It felt like I needed to put on roller skates to even just keep up with all the things that needed to be done in a day taking care of patients. Somebody falls, somebody's, in the bathroom getting sick, and now they need to be cleaned up. It's a tough job.
Well, yeah, but what has changed? Was it ever any better, or now for some reason there's more constraints on the system, or there's more stress? Like, what was it like 10 years ago, 20 years ago, 30 years ago? Was it better or always the same?
The acuity of patients nowadays is quite elevated from what it was when I was working on the medical surgical floors. Back in the day, we had patients that had a hip surgery were in the hospital 3 or 4 days, and now patients are being sent home the night of surgery at some facilities. So the ones that are staying are critical and more acutely ill, which just takes more time to care for those patients. I know that there's staffing challenges and struggles. More nurses are retiring, and newer nurses that are coming into the profession aren't staying. They're quite shocked at what they find when they get out into the workforce and say, wow, school didn't prepare me for this.
Well, again, is it better than in days past, or is it, what is it? It's just a confluence of what schooling is not as good. They're overworked now more than ever, like they're short staff. What is the root cause of this, you think?
Yeah, I think it's multifaceted. I really do. It's higher acuity of patients, less staffing. The healthcare has changed in the fact that we have more knowledge, more technology, which is great. But I think one of the other really big issues that I hear from nurses and physicians even is the documentation. And so they're spending more time at the computer trying to enter all of the information that's going on with the patient, which takes them away from the bedside. So that's another part of the problem too. When I was documenting, it was on paper charts and, you had your time in between treatments or medications or whatever to document what was going on with the patient. So it's tough. It's tough. And, the healthcare systems, their operating margins are quite narrow. And so when they've got to cut their budgets, a lot of times what they'll do is they cut education for nurses. I'm understanding that there's a lot of healthcare systems that are cutting the new graduate programs, which is really the bridge between leaving the education institution and then entering the acute care setting or the hospital. It really facilitates that. Here's how we do it, the transition to practice. And a lot of healthcare facilities have cut back or eliminated those programs.
Before we continue, I've been personally funding the Finding Genius podcast for 4.5 years now, which has led to 2,700 plus interviews of clinicians, researchers, scientists, CEOs, and other amazing people who are working to advance science and improve our lives and our world. Even though this podcast gets 100,000 plus downloads a month, we need your help to reach hundreds of thousands more worldwide. Please visit findinggeniuspodcast.com and click on Support Us. We have 3 levels of membership from $10 to $49 a month, including perks such as the ability to see ahead in our interview calendar and ask questions of upcoming guests, transcripts of podcasts you're interested in, the ability to request specific topics or guests, and more. Visit findinggeniuspodcast.com and click Support Us today. Now back to the show.
What's the consequence of the healthcare facilities? Anything? Or they kill people, no one cares? Like, what happens?
Well, I know it hits their bottom line. There was a study done several years ago that estimated 13 to 15% of hospitals' annual operating income is spent on patient harm. So that can include, they miss the early signs of deterioration and now the patient has to go to the ICU, but the insurance companies don't cover because the patient shouldn't have gone to the ICU. So the hospital has to eat that cost. So another, lawsuits are a big problem too. Patient deaths that happen that shouldn't have happened. Reimbursements are lower than they have been, especially when healthcare facilities don't have very good ratings, like with CMS, the Center for Medicaid and Medicare Services. There's a 5-star rating system, just like your hotels. And if the hospital systems don't rate in the various categories, reimbursements can be lower. There's a lot involved in this intricate system of where we need some improvements for sure.
Okay, so is your book just documenting this? Does it give suggestions on what to do? Like, what's your take on it and what's your role?
Well, there's a lot of things to look at, and I chose to address the one that I had the most experience in, and that is educating patients on what they can do in the healthcare system to remain safe as possible, obviously the name of the book, but it really is taking responsibility for your health and not assuming that the healthcare system, whether it's doctors, nurses, respiratory therapists, that are going to take care of you without incident, because the data, the research doesn't show that. It does show that we have to take it into our own hands, so to speak. And the book outlines stories about harm that has occurred to patients. Some of the patients died. Some of them just had long-term health problems from this harm that occurred in the hospital setting. And really the stories are to give examples of, if this situation you find yourself in, here's things that you can do. But it covers topics from finding a healthcare provider that really you resonate with, that you feel the rapport with, that's going to listen to you, that you have a two-way conversation, that it really is about patient-centered care. I talk about how you can find healthcare facilities in your area. What ratings does that hospital have? On hospitalsafetygrade.org, you can go on there and see if the hospitals in your area are rated an A or through an F, just like high school and college grades, right? And so there's 5 main categories and then subcategories to see how well a hospital performs in the area of safety. For example, does this hospital facility have red, yellow, or green in the category of post-surgical blood clots, post-surgical pneumonia? So if you have your option to go to a hospital with an A rating or a D rating, then that as a consumer is something that you can do to be proactive and explore your best options for getting healthcare.
Do people do any of that, or they just don't feel well, they go to the hospital? Or if they're with their doctor, the hospital the doctor's associated with, I figure they would just go there because then the doctor can see them. So how do they even have choice?
Well, sometimes doctors will go to several different hospitals and you may have your choice. I would definitely check it out if I were going in for surgery. But also as a consumer, I live in the Austin area right now, and I've already looked at the hospitals that are in driving distance of me if I were having a heart attack or, I got extremely sick and had to go to the hospital. I don't want to do that when I'm feeling sick. I want to know which hospital has the best outcomes for caring for patients. So yes, it is something when people learn about this. I was telling it to a guy I was sitting next to on the plane last month, and he's like, wow, I never knew that. And he was going to share it with his family and friends. If you need to go to the hospital, don't pick that D or F hospital. Actually, I haven't seen very many Fs, but there's quite a few Ds in some areas. And I would definitely pick an A or a B over a C or a D.
Where do you get this listing that shows, the grade of the hospital?
Yeah, it's hospitalsafetygrade.org.
Hospital safety grade. Okay.
Mm-hmm. Yeah.
So that's probably like if someone does nothing else, they should go there to see how their hospital ranks.
I definitely would.
All right. I mean, what other advice do you have? What if you're in a hospital, you haven't checked the grade for whatever reason, you didn't know, you're in there and now you feel like you're not getting the kind of care that you need. Either you're the person in the hospital or a family member. What do you do?
One of the other really important topics I talk about in the book, the chapter is on communication. So a lot of family members and patients do not have much, if any, medical background, which is okay, but a lot of them won't even ask questions. So the medical language is hard to understand. It's almost like its own language. And a lot of times healthcare providers, nurses, doctors will explain things in ways that patients don't understand. So your right as a patient is to have information that you can understand. So it's asking the physician, asking the nurse to please explain it. One of the examples I heard when I was with students in the hospital, a physician came in and said to this husband, your wife has congestive heart failure. We need to do an echocardiogram and check her ejection fraction because then we need to find out what her BNP level is and put her on a diuretic. And then really basically walked out of the room. And the husband was like, I have no idea what he said and what that even means. And so it's just saying, having the knowledge and understanding that you have the right to that information and say, please, Dr. Gomez, can you please come back in here and explain that to me? And what does that mean? How can we, make sure she's taken care of? And so it really is the courage to speak up when you think something is wrong, or the courage to speak up and ask questions. We have this hierarchical culture still that puts healthcare providers at the top of this pedestal, so to speak. And we haven't ever learned, I don't think, very many of us, that it's our responsibility to advocate for ourselves and our loved ones and be a partner in the healthcare system. And that's what I advocate is speak up so you understand, and speak up because it is your body and your life or your family members, and make this a shared decision-making model is what I propose.
So what would it look like if a doctor, talks to you in medical speak? What's a sample line that you can say? And what if the doctor goes, or just doesn't seem to appreciate that you don't understand what they're saying? Can you ask for someone else to explain it, or what can you do?
You can. You certainly can. I would just stop the doctor before they leave and say, can you explain to me what congestive heart failure is? What does that mean? That's a new diagnosis. Nobody's ever told my wife she has congestive heart failure. And then understanding, because the families always want to help, right? We want to make sure we understand. So congestive heart failure means that the fluid is backing up in her lungs. Well, why is that happening? Why does she have a weak heart muscle? Well, it looks like she may have had a heart attack in the past. Oh, we were never told that. That's the way that conversation should be going. Okay, well, what can we do about it? Well, we need to monitor her fluids and make sure she doesn't drink too much, in that her heart can handle the fluids that she's been given. And then we're going to give her a medication to offload, make her urinate out the extra fluid from her body so that her heart doesn't have to work as hard. That's the kind of conversation that should be going back and forth.
I just don't see most people doing any of this. And they're advocates or people that can be hired to help families and people in medical care.
There is. Yeah. A lot of hospitals do have patient advocates that they can call. Some don't. It depends on the part of the country and the size of the facility. And there's probably ones you can try and find, on the internet and find a patient advocate. But I think that inquiry is the place to start. What does this mean? What can we do about it? But also understanding that you do have rights as a patient. Like I said earlier, in choosing your provider, you can choose one that respects the patient-provider relationship and that gives you respect as a patient. Some don't.
Yeah, but you can choose a doctor, but not the nurses. You could choose the hospital, but the doctor's only there for a few seconds. It seems like once a week or whatever. The nurses are there most of the time. So I could see the grade of the hospital being far more important than the doctor themselves, unless the doctor overrides everything the nurses say. But even so, the people that you're spending most of your time with, that you're depending to watch you and make sure you're okay, are the nursing staff. So what do you do about them?
Well, you ask politely. So there's a tip that I use. It's called the 3 Ps. It's for families: be present, be polite, and be persistent. So in wanting to find out what's going on with mom, what are her lab results, what does that mean, is having that conversation, number one, and asking the questions. The other part is not assuming because you don't hear anything that everything's normal. And so it's asking and inquiring, hey, Dad had a chest x-ray this morning. Was it normal? Was it better than yesterday? And the nurses definitely should answer those questions. That information's in the chart. Or what was Dad's potassium level this morning? I know yesterday was low, and so they gave him some oral potassium. Is it better today? And then really not just assuming that, like I said, that everything is normal if you don't hear about it, just engaging and asking those questions in a polite way. And if you think something is wrong with your family member, like they're confused, they're not normally like this, it really is so important for the family to speak up and say, this is not like my mother. She doesn't act like this. Sometimes there's something called bias that occurs in the healthcare system, that just because a patient may be over 65 or 70, that if they're confused, the healthcare providers, nurses, doctors assume that they're always confused. But confusion is one of those early signs of deterioration. So if the family member notices that, hey, mom's not quite right, it really is the responsibility of the family member to mention that to the nurse and say, what can we do to find out what's going on with her? Because something's not right. So can we review her lab results? Maybe her sodium's low or high. Can we review what's her blood pressure? A recent set of vital signs. Is she getting enough oxygen? It really is just engaging in a polite way, asking, and then persisting if you feel like something is still wrong and you're not getting a satisfactory answer. There's charge nurses, there's house supervisors, there's on the nights and weekends, there's a hospital administrator on call. So there's always someone you can escalate and ask, hey, we need more help in here. We're not getting the answers we need.
What happens in hospitals, if you say, I don't want to do that treatment because I'm not sure if it's really going to help me or not. I need time to figure it out, or, I don't feel like I'm getting the right kind of care. I want to leave. What will happen to somebody? Because I think there's a lot of fear around, what happens if someone puts their foot down and says no.
Well, we have the right. Our patient autonomy and our ethical rights in the hospital should respect that. Sometimes you may have to sign a paper that says you're signing out against medical advice. But usually, I believe that the healthcare team can work together or should work together with the family. The patient also has the right to get a second opinion, especially if it's a huge treatment plan or medication plan. I certainly would if it was a big deal, if surgery is recommended for something and I'm not quite sure. It's a big surgery and surgeries always have risks. I would certainly get a second opinion. But, the healthcare team should respect that because that's a patient's right. If it's an emergency, it's a little bit different situation. If the patient is deteriorating rapidly, then, you have a little less time you don't have a time for a second opinion usually, but you have a little less time to contemplate and think about it. And that's where you just hope for the best if they've got to do emergent interventions to save your life.
Well, all right. So how would you get a second opinion? Maybe it sounds like a stupid question, but who do you get it from and how?
So usually you have to go through your insurance plan and ask for another provider that's on your insurance. I would ask the nurses too. I mean, especially if you've developed a rapport with a nurse. Hey, is there another pulmonologist that you respect? What's their name? And a lot of times they will tell you, or anybody that's in the medical field that you may know. Call your friends, say, hey, you had a heart attack last year. What did you think about your cardiologist? That's how I would do it. It's hard to get. There's a lot of physicians have Google ratings or whatever. You can look them up that way, see what their ratings are. But I would just honestly ask friends, anybody in the healthcare or anybody that's had experience with whatever it is, a nephrologist, a cardiologist.
Okay. All right. So what's, I don't know. I mean, what do you have like a clear plan of action for people when they're in hospital or when they're dealing with their providers, or is it very situation based? Like what's the summation of advice? It sounds like you're giving it second opinions, check everything, that kind of stuff. But I don't know, like what impediments do you see to people that, aren't used to dealing with healthcare? It's an acute situation. They haven't dealt with this maybe before ever. What are some things they can do?
Well, honestly, we live in an information age that you can find so much information on the internet. And yes, you have to make sure that it's vetted to be like WebMD is a great place to go ask questions. Is this normal? What should I do? What could this be? And it really is becoming informed on whatever situation. Like you said, chest pain is different from kidney stone, is different from neurological changes or a brain bleed. And so, but there is a lot of things that's just universal. So advocating by speaking up when you feel like something's not right or you don't have any answers, understanding what normal vital signs are. And I outlined this in my book too, because that's important, because you do need some kind of baseline knowledge to know what's right and wrong with a patient, whether it's yourself or your family member. So for example, knowing that normal heart rate for an adult is anywhere between 60 and 80 beats per minute. If mama's heart rate is 100 and staying at 100, something isn't right. And so it's, hey, can you check mom? Something's going on with her, and bringing it to the nurse's attention. As we said earlier, they'll come in the room, pass their medications, and then go on to the next patient and not really pay attention. And I think that's where, honestly, families can be a real blessing to the patient in the hospital when they're going through these acute incidences. But, becoming a little bit knowledgeable about what's a normal blood pressure, gosh, mom hasn't had any urine output for a while. Is that normal? Well, no, it isn't actually. It means that there's decreased blood flow to the kidneys if they're not putting out much urine, or the patient's very dehydrated for some reason. And so it's watching those physiological signs change that we just need to hone in on and bring to the attention of the healthcare team is probably the best. I know it's a broad area, but it's the best thing you could do. So peripheral circulation, is there a pulse in that right arm that mom just fell and broke her arm? And now the hand is a little dusky and now it's cool. Well, something's going on that she's not getting enough circulation there. And could be a medical emergency really soon. So it's tuning into those particular things. Does that make sense?
Okay. Yeah, that makes sense. Well, very good. What's the best way for people to, to start learning? Should they go through your book first, or is there another organization, or? There
is a lot of patient safety organizations out there, but I think honestly, I wrote the book as kind of a primer for an overall picture. I think it's 228 pages or something. And you can flip to, if you're having surgery, just look to that chapter that will discuss, what should happen before surgery, after surgery, if tubes and drains, IVs, lines, that type of thing is you're in the hospital and now mom's got this tube feeding and you're not sure what is the proper care that should go with mom having a tube feeding. And just give you a clue, it's the head of the bed should never be flat. Because if that liquid food is going into mom's stomach, if we lay down flat, that food can go, or that liquid can go inadvertently into the lungs and cause aspiration pneumonia. So it's those little things that you can turn to that chapter. I think it's a good read only because it's, got the information, but it also is related to stories so that patients and their families can relate to those things. On my website, which is just drjuliesiemers.com, I've got blogs on various things about healthcare. And I post a new one every week. And then I've got some little ebooks that I wrote. It's on my website as well. So different places and other websites too that have resources for patients' families. The biggest thing I would say is just become informed. And I suggest doing it before you need it. Because if you're waiting till a crisis happens, then the anxiety and the stress, we don't quite learn as much or understand as much. And, it's kind of that situation you don't want to find yourself in. But we're all going to be a patient someday or have a family member or a friend that's a patient someday.
Gotcha. Okay. Well, very good. And I appreciate you coming on the podcast. Again, can you just restate the name of your book? And I'm sure it's on Amazon and Kindle and everywhere.
Yes.
Before we close out.
Yes, for sure. Surviving Your Hospital Stay, a nurse educator's guide to staying safe and living to tell about it.
Well, very good. Well, thank you so much for coming on the podcast. I really appreciate it.
Thank you. You're most welcome.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed. At findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed. Advice is needed.